All yours.
Good morning. I'm John Fontaine, electrophysiologist. I'd like to thank Dr. James Carter and the organizers for inviting me to participate in the Colorado ACC Heart Failure Summit. The topic today for me is update regarding SVT and atrial fibrillation management. I have no disclosures relative to the content of this presentation to announce. So this is an overview of the subject and subheadings that we'll discuss today. And it seems to be sort of a long list, but given the sophistication of the audience, I think that we can handle receiving this information. We're going to talk about inappropriate sinus tachycardia, often confused with atrial tachycardia, atrial flutter and atrial high rate events, atrial fibrillation management, detection, cryptogenic stroke, catheter ablation. This is a heart failure summit. We'll talk about the Castle AF data briefly. We'll look at some racial implications of the recent data from the Cabana trial, COVID-19 and its relationship to atrial fibrillation compared to other viral infections, as well as some updates on cryoballoon and pharmacologic therapies, as well as a new therapy or modality called pulsed field catheter ablation technology. Inappropriate sinus tachycardia has been around for some time. It's not a new entity, it's a known entity. However, patients often present with these palpitations and are confused with having atrial tachycardias or other forms of tachycardias. The clinical syndrome is characterized by non-paroxysmal palpitations occurring at rest or sometimes during the early phase of exercise, and most notably seen in women. The etiology is unclear. There are other associated symptoms besides palpitations, such as malaise, fatigue, headache, dyspnea, or orthostatic intolerance. The pathophysiology is unclear, but we know that there's augmented sympathetic activity. And in some cases, laboratory findings have noted that IgG antibodies against the beta receptors have been discovered. In prior days, in the old days, I would call it, we used to perform ablation therapy for these patients, but sometimes these arrhythmias would recur in other parts of the crista terminalis or the sinus node, and therefore render the ablation therapy somewhat not effective. Beta blockers are often effective, but not well tolerated in young people, and also because it may produce some hypotension. Ivabradine, as you know from your heart failure experience for this group, has been published as an effective agent that abolishes symptoms in about 20% of these patients. Now, those studies have been very small because the entity is not that common, and most data you find include a study of about 15 to about 30 patients. Ivabradine, as you know, blocks the funny channel or the sinus node channel called HCN4 channel, which slows sinus node automaticity. This results in decrease in heart rate and effective control of symptoms of inappropriate sinus tachycardia. In contradistinction to the postural orthostatic tachycardia syndrome, which is often confused with inappropriate sinus tachycardia, these patients have orthostatic intolerance and orthostatic tachycardias in the absence of hypotension. So a tilt table test is effective in differentiating these two etiologies and providing the appropriate therapy. Nonetheless, ivabradine has also been found to be effective in the treatment of postural orthostatic tachycardia syndrome. Let's look at atrial flutter. This is a cutout of the septal view of the right atrium, showing the cavo-tricuspid isthmus at the arrow. Now, this shows the area that we target for ablation therapy, which is often successful in about 90 to 95% of cases. The isthmus-dependent, or cavo-tricuspid isthmus-dependent atrial flutter is the common variety of atrial flutter we often see in the clinical arena. Also, atrial flutter can occur in the region of the mitral annulus or the mitral isthmus. This is seen sometimes in patients with mitral valve disease or dilated chambers or mitral regurgitation, and also can be ablated by creating an ablation line between the mitral valve annulus and the left inferior pulmonary vein. Can also ablate by creating a line between the left superior pulmonary vein and the mitral annulus. Other types of atrial flutter can occur from the roof of the left atrium, particularly as a result of non-contiguous lesions created along the roof in the attempt to treat atrial fibrillation. Now, we can turn our attention to atrial fibrillation, risk factor assessment, clinical settings, and the management of these patients and their comorbidities. As you can see on this graphic, there are a number of reversible and irreversible risk factors or non-reversible risk factors associated with atrial fibrillation. The guidelines currently advocate the use of aggressive therapy of sleep apnea, obesity, hypertension, and diabetes as a class 1 recommendation that can either precede or be used adjunctively with other treatment modalities such as catheter ablation or perhaps pharmacologic therapy. But addressing these risk factors are germane and important in providing beneficial outcomes and decreasing the recurrence of atrial fibrillation. As you know, the prevalence of atrial fibrillation increases with the severity of heart failure. Patients with heart failure may have an incidence or prevalence of atrial fibrillation from 10% in those with maybe New York Heart Association class 3 status to 50% of patients with New York Heart Association class 4 heart failure. In comparison, patients with atrial fibrillation, only about 10 to up to 20% of those patients may develop clinical signs of congestive heart failure. As you know, catheter ablation have been utilized to manage atrial fibrillation in patients with heart failure. And this is shown by the paper published by Marouche a couple of years ago, whereby patients who met standard criteria for device implantation were identified as having atrial fibrillation and underwent ablation therapy despite having New York Heart Association class 2 or more heart failure. Although those results are in a group of patients that proves to have sort of a low-powered study, the results showed there was improved all-cause mortality and fewer admissions for worsening heart failure in the ablation group versus the standard of care therapy. Excuse me. Catheter ablation also improved cardiovascular mortality and hospitalization in this group of patients with heart failure. Now, there are some knowledge gaps that exist relative to the assessment of atrial arrhythmias or atrial high rate events and thromboembolic risks. There are several studies that have been undertaken to assess what truly is that risk, if in fact it exists. As you can see in this column, the first column, the ASSERT trial was one, probably the largest prospective trial undertaken that had 2,500 patients. All were over the age of 65 and had hypertension, none with a history of atrial fibrillation. The follow-up period was about 2.5 years in that study, and atrial tachycardia was defined as an atrial arrhythmia with a rate of 190 beats per minute that lasted at least 6 minutes. In that study, the burden of this arrhythmia was 10.1% in the first 3 months of the study and 34.7% during the entire follow-up period. What's noteworthy is that if you had 24 hours of this arrhythmia, you had a 2.49 hazard rate of having a stroke. Now, what's really notable is that only 26 of the 51 patients who had an atrial high rate event with a stroke, whereas most of those patients did not have any arrhythmias associated with a thromboembolic event. In a separate study, the TRENDS trial, which also looked at patients who had cardiovascular implantable electronic devices or pacemakers and defibrillators inserted, there were 2,486 of those patients. Some of those were had atrial fibrillation, about 20% had a history of atrial fibrillation, but not at the time of inclusion in the study. The follow-up period is 1.4 years. The atrial tachycardia then was defined as an atrial rate above 175 beats per minute, lasting 20 seconds. 47% of those individuals had this atrial high rate event during the follow-up period. However, in comparison to the ASSERT trial, the criteria that separated those with thrombotic events from those without was a duration of 5.5 hours as opposed to 24 hours. Now, what's really important in these 4 trials shown in the bar graphs, of the ASSERT trial, TRENDS trial, and 2 other trials, if you look at the atrial high rate episodes and thrombotic events that were identified, 49% of those patients with a thromboembolic event did not have any high-rate episodes. And in the trend study, 35% of those patients with a thromboembolic event did not have any high-rate episodes. So therefore, this led to the postulation that an atrial myopathy or a hypercoagulable state may be responsible for these thrombotic events. When we compare monitoring strategies in patients with cryptogenic stroke, we know that the typical Holter monitor assessment shown on the right is useful, but the implantable cardiac monitor is the best means of assessing and detecting atrial high rate events or atrial fibrillation. As you will see in this particular trial, which is part of the Crystal AF trial, if you look at the subjects with atrial fibrillation detected over a 6-month period, we find that the implantable cardiac monitor was far more effective in identifying patients with risk of thrombotic events or to explain the previous thromboembolic event that occurred in those suffering cryptogenic stroke. Cryoablation, it's a new modality, as you know, but not that new, but it involves taking a balloon, placing a balloon by the femoral vein access into the antrum of a pulmonary vein and applying cold energy or a cryorefrigerant to the site to cause convective cooling. Convective cooling is the means by which we can create a durable lesion in the antrum to treat atrial fibrillation and isolate the pulmonary veins. The pathophysiology of ice formation, or the ice creation, is that applying applying ice delivery to the antral site, it causes a hypertonic extracellular space when extracellular ice formation occurs. This extracellular ice formation results in an osmotic gradient that is external to the cells and therefore causes a diffusion gradient whereby fluid will egress the cells. Intracellular ice formation will occur, disrupting the enzymatic activity in the cells, disrupting membrane lipoproteins and cause cellular death. The subsequent hyperemic state also contributes to the greater osmolarity in the extracellular space and greater degree of apoptosis. We look at the early studies of the cryoballoon procedure. There are these 3 studies conducted in about 750 patients, all favored the cryoablation technique for abolishing atrial fibrillation recurrence. Symptomatic relief of atrial arrhythmias also favored cryoablation. And if you look at the asymptomatic state after a 12-month period, aside from the acute period, those results collectively also favored cryoablation procedure. The quality of life scores were also in favor of cryoablation relative to antiarrhythmic drug therapy. So there's been renewed interest in delivering therapies or providing specific therapy for atrial fibrillation early on in the course of atrial fibrillation. We know that atrial fibrillation that is paroxysmal can progress to persistent and permanent forms of atrial fibrillation. So the concept that early rhythm control was studied by Kirchhoff and colleagues as part of the East AF-NET4 trial investigators. And the results were those that from the comparison, those that resulted from occurred from as a result of utilizing initial rhythm control therapy plus usual care therapy compared with usual care therapy alone. And we can see here, if you look at the cumulative incidence of recurrence of atrial fibrillation, usual care was associated with greater recurrence than early rhythm control. Most of those patients in that study did receive flecainide therapy or other kinds of class 1 to 4 Williams classification drugs, although flecainide seemed to be the more prominently used agent in that trial. Well, we know the Cabana trial results show that there was no significant difference between antiarrhythmic drug therapy and ablation, although that study was had a lot of crossovers which impacted the results, as Doug Packer will tell you. This analysis is from Kevin Thomas, who looked at the racial ethnic minority population and their response to the ablative procedure versus medical therapy. You can see on the left, there were 65 racial ethnic minorities who received ablation therapy compared to 587 non-minority groups. And the drug therapy comparisons, there were 65 racial ethnic minorities in that group. And you can see that the freedom from recurrence favored the ablation procedure in the small subgroup of patients. However, when we looked at the event rates, we find there's a greater number of event rates in the patients who received drug therapy. Now, these patients also had higher incidence of heart failure, hypertension, left ventricular dysfunction, and also kidney disease in that subgroup. So what we can gather is that, well, one, we know that Blacks have more hypertension than non-minority counterpart. And in that particular study, heart failure and other comorbidities were more common. But what was concerning was that the sudden cardiac arrest in Blacks in that medical group was 6.3% versus 2.3% in non-minority groups. And this has not been well explained. This led to my writing a letter to the editor that was published in November of this year, addressing that issue. We know that there's a new study underway now called a pragmatic randomized clinical trial of early dronedarone versus usual care to change or improve outcomes in persons with first detected atrial fibrillation. I'm on the steering committee. The principal investigator is Jonathan Piccini from Duke, and we're really enthusiastic about starting this trial. I think you might be interested in knowing that the first patient is anticipated to be enrolled sometime by the end of this year, and we look forward to this analysis. Well, we know that now there's a battle between is early treatment with pharmacologic therapy versus early intervention with catheter-based approaches are beneficial in patients being treated for atrial fibrillation, and the result is anticipated and might change the practice that we have in managing AFib today. What's also new is the post-field ablation procedure for atrial fibrillation management. This entails the delivery of high-energy, tissue-specific electrical energy to a site, the traditional PVI site that we target in the attempt to cause durable lesions and prevent atrial fibrillation from recurring. The interest in this technology is that utilizing a special delivery system that whereby a special catheter is placed in the antrum. We know that because the electrical energy is tissue specific, there is no collateral damage. So in this initial trial of over 100 patients, we see that esophageal damage was 0%, motility disorders did not occur, fistulas did not occur, pulmonary vein stenosis did not occur, phrenic nerve injuries did not occur as well. And so we know that this targeted approach utilizing the electrical energy may be a wave of the future in managing atrial fibrillation. And one more point about atrial fibrillation and COVID-19. We know that there's been the pandemic has affected a number of individuals, and this study, which was published this year in JACC, looked at the incidence, predictors, and outcomes of atrial arrhythmias in patients with COVID-19 between February and March of 2020, in comparison with the influenza virus infection that occurred in patients between 2017 and 2019. This was a retrospective analysis. There were 3,900 patients in the COVID group. 1,110 data were abstracted manually, aside from the automated electronic record data abstraction. And what we can see is that when you look at the diagnosis of atrial fibrillation, we find that 10% of the COVID patients had atrial fibrillation. New atrial fibrillation was found in 4% of the COVID patients. When you look at the manual abstracted data, which was a little bit more specific and sensitive for picking up these arrhythmias, you had 13% incidence of atrial fibrillation, and 6.6% of those patients had new onset atrial fibrillation. When you look at the influenza group, we find that of the 1,420 patients included, 12% of those had atrial fibrillation and flutter, and 4% had new onset atrial fibrillation and flutter in the hospital. So therefore, there is really no significant difference in the incidence of atrial fibrillation among patients with influenza or COVID-19. The risk factors that were predictive of atrial fibrillation were one, the presence of inflammatory markers such as CRP, C-reactive protein, or IL-6, myocardial injury as suggested by elevated troponin, or patients who were intubated or required vasopressor therapy or steroid utilization. The COVID-19 patients did have a higher mortality in the hospital compared to those with influenza, but those without atrial fibrillation or atrial flutter, there was no significant difference between the influenza group and the COVID-19 patients. I thank you very much for your attention, and I'll answer any questions you may have via James Carter. Thank you.